No?
So you might need this soon then. You don't want to stretch.
Now, if you want, we can proceed. I thought you need just a short break. No? Okay. So, my name is Dr. Hoffmann. I'm an orthopedic surgeon. I was asked to talk about implant design and evaluation. I didn't know really what do you want to hear, but I do a lot of teaching with students, so I tried to make it a little bit more practical. That's a place where I work. It's in the middle of nowhere. It's 3 hours from here. At the top of a mountain. It's a skiing resort, and the hospital is a crazy hospital, really at the top of a mountain. And you see, during winter time we have a lot of snow. In summertime it's hiking. If we talk about implants, we always have to talk about disclosure. I'm a consultant of Zimmer Biomet, which is one of the leaders of producing these implants, and a speaker agreement of Synthes. But I try to keep my lecture without of any conflict of interest and company bias. The only thing you will see, all my pictures and the examples I brought to you on the implants are from Zimmer Biomet. That's probably the only bias you will see during my talk. So again, Stolzheimer Hospital is one of the largest orthopedic departments. We do everything except tumor surgery because we don't have an oncology department. It's a pure orthopedic hospital. We have, 20 years ago, we were the first hospital in Austria who completely subspecialized. This was new for Austria. I mean, it was in other countries already, mainly in the US. That means the spine people do only spine, the hip people do only hip, the knee people do only knee, but they do everything. For example, at the knee, from scope to cartilage repair to ligament reconstruction, uni, totals, revision, osteotomies, so the whole stuff. So we were one of the first hospitals doing that. In summary, we do about 1,300 big joints. We are also a referral center, so we get a lot of referrals to our hospital, so we do 150 revisions, and we are, since more than 20 years, a training and learning center for surgeons and students. So for surgeons, we offer a whole program with instructor courses, with life surgery, surgeon-to-surgeon fellowship program, expert meeting, and believe it or not, in the last 15 years, more than 3,000 surgeons from more than 70 different countries were coming to Stolzheimer Learning Center. But we also do a lot with students. We are an academic teaching hospital of the University of Graz. And interestingly for you, we do since years an international student week for 1 week together with EMSA at our hospital. So the students are coming for 1 week, work with us, we do some courses for them, and they can enjoy the environment of the hospital. So if we talk about artificial orthopedic implants, we have to separate between large joints. This is a patient of our hospital, a typical rheumatoid arthritis patient. You see she has all 6 major joints replaced, which for a rheumatoid patient is not unusual. And probably these joints are the best joint in her body. So we can do a lot for these patients. So these are the large joints to replace. And we have nearly for every joint in the body, we have now solutions, spine, hand, elbow, foot and ankle, which are the small joints. Whenever you have a question, I want to keep it a little bit interactive. Please don't hesitate to ask the question and interrupt me. So to talk about implant design and evaluation, I want to focus on the knee side because otherwise the topic will be much too broad. So the key points in the next 30 minutes I want to share with you is what is the success of an artificial joint and how to choose the right implant design. I will talk a little bit about basic biomechanics for artificial knee joints, and I will show you the classical available designs and the modern designs on the market. And if you go down to the booth, you will find probably all these modern designs we discuss. I will go a little bit in the characteristic of the 3 classical designs. And the last topic I want to share with you, there are still failures, especially early failures, which are disaster. And what is the problem? Why the modern total knees might fail. So the key factors for success, first it is the patient. And if you look at this patient with morbid obesity, it's very difficult to change the risk factor of this patient because this patient should lose 60 kilograms minimum. Otherwise, you don't change anything. So the patient is the problem, because there's a clear link between obesity and osteoarthritis of the knee. Interestingly, there is not a link between osteoarthritis of the ankle and the hip, but to the knee. And a lot of patients coming for a total knee are obese. And it's difficult to change that. I mean, you can tell him, lose not 5 kilograms, lose 30 or 40. So we have to deal with the patient factor, which we cannot change significantly in most of the cases. The most important message, and this is something we also share with the surgeons, is 80% of the success, if you do an artificial knee replacement, is the surgeon and his surgical skills and his instruments. It is not the implant. If you go down to the booth, the companies will tell you it is the implant. If you use my implant, your patient will be younger, more sexy, having better sex, 20 years younger. This is not true. So the implant itself, in my experience, is maximum 20% of the success. So the majority is the patient and the surgeon. And most modern designs are doing well because they are now controlled. We will come later by registrars, and they give a warning. So most of the modern implants are well controlled, they work, but don't trust the companies what they try to offer you and say we will have the best thing for your patient and whatever. And the implants itself have a limited influence on the outcome. Definitely you need to have a good implant, but there is no difference between a BMW, Mercedes, or whatever. They're all good cars, good implants. So let's go to the key factor of the patient. One of the keys for us surgeons is that we identify the risk factors of the patient. So we have to screen every single patient on risk factors. And if we can improve the risk factors, we postpone the surgery, we send him home. We tell him, for example, your diabetes is not well controlled. If you do the surgery now, your risk for infection is 4 times higher. If we control diabetes and you come back in 3 months, it's done. So this is something we have to do. The problem is we cannot change the deformity of the patient. So this is an extrarticular deformity after a not well-healed fracture here. We cannot change that. We have to solve that with our surgery. Either we do a correction osteotomy here, or if it's an old patient, we have now the techniques to correct everything in the joint. So we have to deal with the deformity of the patient and the difficult situation. A very important point, what we learned only during the last 10 years, is that's the communication with the patient. So we have to educate the patient and we have to give them information. I give you an example. So in the classical situation, when the professor was going in the UR, he said, is this a hip or knee, what I'm going to do? So he had no idea on the patient identity. Nowadays, at least in my hospital, every surgeon has to talk directly to the patient the day before surgery. Because this is the last chance to do the last follow-up and the last decision-making if everything is well done. And for the patient, it's a very important psychological factor to talk to the surgeon. And I always tell my surgeons, you have to touch the patient. I call that the magic touch. If you touch the knee of the patient, you get a relationship. And this is very important for the patient, but also for the surgeon. And we have to talk about compliance, because part of the success of any surgery is that the patient follows your restrictions and your recommendations. And what we found also in the last 10 years is that expectations are very important. So a lot of patients coming with wrong expectations. So they think they get the same result than their neighbor, which had a straightforward knee with a difficult post-traumatic situation, for example. So it is important that the expectation of the patient is here, and here's the quality I deliver. This makes a happy patient. If the expectation is here and the quality I deliver, guess what? The patient will not be happy. So talking of expectation is now very important. I see patients coming for a total knee, for example, to increase their golf handicap. That's not the right target, and you have to talk about the expectation of this patient. And we have more and more an issue in orthopedics with the new arthritic patients. They are much younger, so originally the patients getting a total hip or knee was 70 plus. Now the average is 65, and it's getting younger and younger, and they are more active. They don't want to have just pain relief, they want to have better function. They are definitely more obese, especially the knee side. We see a huge endemic problem with obesity, and they ask for better function and higher quality of life. That's the target. And on the other side, these patients, in Austria, the average expectation to survive is 83, 85. So the young patient might need an implant which will survive for 30 years, which was not the target times ago. And this is now the bad message, and this is depending from which country you are coming. The numbers of total knees, especially total knees, total hip will stay constant, but total knees, the numbers in the next 10 years will be double or 5 times the numbers. So there will be a big boom of total knee surgeries in your countries. The question is who will pay that and which will be the surgeon doing that volume. This is the socio-economic problem with total knees. The next is never tell a patient hip or knee, but knee more than hip, did you get a completely pain-free situation. Because there might be some residual pain. It's an artificial joint. It's not the nature getting back. And this is a nice study from France. They looked at well-done total knees, and they developed this so-called Nobel Vice score. So you can look, for example, for gardening, swimming, sailing, so all these daily activities. And only 68% of well-done total knees said, I have a complete normal feeling with my knee. That means they don't have the natural feeling, the majority. Only 60% were completely pain-free. So never promise a patient you will be completely pain-free. You can tell them we will significantly decrease your pain, may make your quality of life better, but again, you will not be 20 years younger. And only 70% of the patients were as active as before when they did not have osteoarthritis. So this is something you have to tell it to the patient, because with the social media and with the direct patient marketing of the companies, this is one of the disasters. Companies go direct to patients now. And they sell their products and tell them, you will be perfect, you can do skiing, you can do hiking, you will be 20 years younger. So this is the problem we are facing when talking about expectations of the patients. The next question is which implant for which patient? The most important thing is that the type of implant is mainly a philosophy. There is no evidence and there's no literature who clearly is in favor of one of the modern implants. Everything is a lie, everything is a marketing. Because company, they have to sell their product as being the best. But there's no evidence. It's mainly a philosophy, and most of the surgeons still use the implant they were trained. So if you learn driving by a kind of car, you will like your first car. That's your favorite. And the same is with the surgeons. And sometimes there is commercial or whatever force on the surgeons to decide which implant he's going to use. So it's mainly philosophy. There's no evidence. The next question is, can I use one standard implant for all my patients? Definitely not. Look at this post-traumatic malunited proximal tibia fracture. In this old lady, this is a CT scan. You immediately recognize that here is a big problem. You have to solve that big bony defect. And the ligaments here are not stable, they are floating. So you need something different than a normal knee. So you need special implants for special situations. And what are the special situations where you cannot do your favorite primary knee, you do probably every day, if you have ligament problems like here, or you have huge bony defects. Then you need specific implants to solve that problem. And last but not least, the scientific part. To choose an implant, these are the functional data of the implants and the survival data. And I already mentioned there is not really evidence that one of the implants is in favor up to another one. So what can we use? We can use joint register data. Did you ever discuss joint register data? So far not. So joint register data are now coming nearly in every country, but it's not available everywhere, but we have about 15 joint register data worldwide. The problem there, the end point in the register data is just revision. So they don't count for the function or satisfaction of the patients. if it's not revised, it is a successful implant. And I tell you a story. There is one English implant which is so difficult to be revised. It's a disaster implant. They have 0 revision rate because nobody wants to revise it. But the implant is a disaster. So you see, looking only at the revision as an endpoint is the wrong endpoint. But this is how they started. Now, some of the registers used now for the PROMS. PROMS is patient-reported outcome. That means it's quality of life and function. And there is a big discrepancy between revision rates and PROMS. And PROMS is what the patient is of interest. Is my knee functioning? Yes or no? I am happy with that? Yes or no? And the problem is, especially in total knee arthroplasty, 80% of the patients are only happy with their implant worldwide. That's not a problem of a single country. And more than 95% of the hip patients are happy. So there's a big gap between these two surgeries. The next bad news is the published literature. Because the published literature, 30 to 80%, depending where you come from. In the US, is up to 80%. In Europe, is between 30 or 50% of the published literature comes from the inventors. That means there's a significant developer bias. Why? Being a developer, the company will not allow you to publish bad results. You will never hear about bad results. You only hear about the top of the cream, but you don't get the reality. And we have to be aware that the published literature is a mass of company-biased information, at least at the implant side. And we have to know that. And we have to filter the published literature. And Labeck is one of the guys who does a lot of scientific work on this side for the European Effort Society. And finally, it's the personal experience and the personal preference. So for example, I was trained 30 years ago, and I changed 20 years ago to one company, and since 20 years I work with the same company because surgeons are very conservative. You have 2 types of surgeons. One is the very conservative, never change a winning team. You're happy with an implant, you don't change it. And you have the other type of surgeons, and probably these are not the best ones. They always want to drive the latest version, the big Ferrari. But they can't drive it. You know, they have 500 PS now, and they don't know how to drive this car. So this is the other disaster. If you always change, I know surgeons, they change their implants every week. And say, I use always the latest fancy whatever. How can you do that? You have a learning curve. You have to be aware what you're doing. So that's all the problems on the surgeon side. Now just an example from the Swedish registrar. This is from 2016, the latest one. What they do now regularly, they look at all the implants used in Sweden, the main implants, and they use one implant as a reference. Here is the PFC Sigma. And all the red ones are doing significant worse. And they call it an alarming. There's something wrong. Because if a whole nation gets problem with this implant, it is not the surgeon factor, it might be the implant. And the blue ones are doing the same, and the green ones are doing significantly better. Now, this is information you have to be very careful. You have to go into depths what is behind that, but at least we have now some data that shows you are in the safe zone if you use a blue and green one. You should look at your implant if you have a red one and a warning. And in Sweden, they break it down even to the hospital level. And in England, the register, I don't have a slide here, they break it down to the single surgeon. So every surgeon in England has to put in his implanted numbers, otherwise he will not get reimbursed. That's another question. If you don't link it with money, surgeons will not do the paperwork. So the only way to get the surgeon doing the paperwork is you don't get money if you don't do the paperwork. So in England, they don't get paid if they don't do the paperwork, and they break it down to the surgeon. So every surgeon can see his personal data related to the rest of the community. Not to others, but his own personal data. And believe me, if a surgeon is in the red line, he get a warning. If he doesn't change, he get a meeting. And on the 3rd time, he will not be paid anymore. That means he has to stop. So this is how they do it in England. So this is how to select an implant. Are there any questions so far? on the marketing, on the bias of the literature, on registrar data. Any experience with these data? Nobody. But in every country, wherever you come, this will be the future. Because if you talk about cost effectiveness, the first question is quality. And this is quality control, one part of quality control. And the most important thing for us surgeons is that we can, and I work with the company since 30 years, the most important thing for us surgeons is to get out of this company pressure. We have to be independent. We have to say this is the wrong development, this is dangerous, or whatever. But they pay a lot of money not telling the truth, believe me. That's the problem. So let's go to the basic biomechanics of TKA surgery. And I brought you some implants that you can see it. So first is the constraint. The constraint is the coupling mechanism between the femur and the poly. And we have so-called non-constrained, the CR prosthesis. And the CR prosthesis are like this. So you have a poly. Originally it was completely flat, now it's a little bit dished, so all the modern CRs look like that. And you have a femur, and the PCL is intact, and you can see that this is nearly free of conformity. So there is motion guided by the ligaments. So anterior, posterior, medial, lateral, and rotation. You can give it around. This is a CR knee, which with no constraint. So there's no coupling mechanism between the femur and the poly. And the other one is the posterior stabilized and the rotating platform. And this is a complete different story. There is a coupling mechanism between the plastic and the metal. And the coupling mechanism is this plastic pack and the cam mechanism. So you see, rotation is not the same like before because it's more conformity, but it's still open. But there is this cam and peg mechanism here, which guides the femur in the rollback, the metal and the plastic. So this is the PS, which is hemi-constrained. I don't have an example for rotating platform. And finally, we have the higher constrained ones. We will talk later on that. This is the revision or difficult primary. As you can see, this plastic pack is much bigger. It's inside with metal, and the box is also bigger. And now the difference here is, if you have insufficient medial lateral collar ligaments, this is substituting for insufficiency. But it's the same rollback with the cam and peg mechanism, but it is substituting your medial collateral ligaments, which is the CCK, called it a constraint, or VVC, valgus varus constraint. And the last development is the third generation hinges. They are completely linked, but the third generation hinges have the advantage that even they're completely linked, so they don't have an anterior posterior movement, they have complete medial lateral stability, they allow some rotation, but the trick is the load is on the poly. So this is the third generation hinge, which is the other constraint. So these are the 5 principal types of prosthesis. And again, if you go to the booth, every company will show you one of these types with extra features. But the concept comes back from that. And we talked already about conformity. Conformity means the bigger the contact area between the metal femur and the plastic, the less guided motion. So the CR has a very small contact area, but the price to pay is, if the contact area is very small, the forces on the poly is very high. And the other thing is that complete high conformity, that the femur and the poly is nearly 100% conform, then the stress is very low, but the force on the component and the fixation is very high. So every implant has to decide high contact area or low contact area, and this makes a big difference on the biomechanics and the fixation. And all the implant developments are not new. They were started in the 70s. So these classical 3D signs, CR, PS, and rotating platform, they were designed in the 70s, so more than 40 years ago. And from the principle, they have not changed. It is like, let's say, the BMW, the Käfer, the original one. I mean, it had changed the design, but the principle of the car has stayed the same. And we have a lot of modern designs. Again, it's the same with the car industry. A company who does not come up with a new design within 5 or 6 years, they believe we will lose marketing shares because surgeons don't want to put in a component which was designed 40 years ago. And again, I showed you the two revision components, CCK and hinge. So a little bit on the biomechanics of the CR. If you look at the femur, the radius of the medial and lateral condyle is different because it has that rollback by the ligament. The poly is more flat. The contact area is very small. And the motion is guided by the both collateral ligaments and the PCL. Because in nearly all total knees, the ACL is gone. You will find now two companies who offer an ACL, PCL preserving prosthesis. So ACL is intact, PCL is intact. First of all, about 1/3 of the patients, the ACL is intact. So there are patients who have an intact ACL. But the problem is very simple. And I told them from the beginning it will not work, because if both ACL and PCL is intact, the compromise you can do for the patient is less than 1 millimeter. So if you want to do that, you need an individual implant for all of us. So you will have a completely different knee than I have, definitely. And using a standard knee with both ACL and PCL intact will not work. But who can pay that to make an individual prosthesis for everyone? And the next question is a technical question. Which surgeon can put that in? Because if both ACL and PCL is intact, it's technically very demanding. Very demanding. And again, no compromise allowed. So again, by the CR, it's guided by the ligaments, and especially the PCL is the major structure, and this is one of the disadvantages. If the surgeon does not know how to deal with the PCL, this prosthesis doesn't work very well, because it needs a perfect PCL that the biomechanics works. The PS, I already told you, you see that plastic pack and that cam mechanism, and going to flexion, this is guided motion for the flexion. And even in the frontal plane, you see it is round and round, so it's a little bit more forgiving. And an artificial joint will never work like a natural joint, so you need a simple biomechanics which is forgiving, and the PS is the more forgiving implant design. But you have to take out the PCL. Now a little bit the literature, CR versus PS. The problem again for the CR surgeon is to deal with this biological structure, the PCL. But if you do it right, it works. But if he makes that PCL a little bit too tight, if he goes in flexion, it's like an open book, and the patient will have pain and he cannot flex. If it is too loose, the opposite happens. If the patient wants to flex, the knee is not flexing, the femur is sliding anterior because the PCL is not working. But if you do it well, there is no difference to the PS. But it's surgically more demanding. And not many surgeons recognize if they do a CR, it's more demanding and they have to deal with the PCL. So if you look at all the data of the registrars, Cochrane and meta-analysis, Cochrane, you know what Cochrane is? Yeah. Cochrane and meta-analysis, it is clear. CR show us a little bit better survival. And this is also something surgeons have to understand. You have to go into detail. The little better survival of the CR is because CR surgeons do CRs in straightforward knees. If it's getting to get a difficult knee, they do PS. And this is explaining the difference between CR and PS. Because it's not for all knees possible. You cannot do every deformity with a CR knee. The PS has a little bit better flexion, but again, this has something to do with the surgical technique. If the CR surgeon deals the PCL right, you get the same range of motion and the same result. So finally, in summary, no difference between CR and PS. It's again the surgeon and his surgical technique. The mobile bearing design, this was a revolution 35 years ago because it's a complete new concept. And it was a very interesting new idea, because Büchel and Pappas, who developed that, they made two articulations. They made the articulation between the metal and the plastic, which is high conform, and to get rid of the stress, they made a second articulation, which is the rotation on the lower level. So you have a dual articulation concept, like the RHK. The RHK is a mobile bearing. You have a rotation on this level, and you have the flexion extension on the other level. So this was a great idea, and everybody thought this will solve all the problems we have with total knee arthroplasty surgery, and now we have second and third generation, and every company here at the booth offers this mobile bearing concept as an option. So the companies at all, they offer you all the options. Most of the companies offer you everything. It's like the car industry. You want to get a customer, so you want to get a BMW or Mercedes, a Ferrari, you can get everything, because you want to get the surgeon as a customer. Now, again, if you look at mobile bearings and fixed bearings, if you look at the data, the fixed have a different type of wear, because everything is in one articulation only. The mobile has a second articulation surface, which gives less volume wear, but more small particle wear. And I don't know if you ever heard that, the osteolysis process, that means the inflammation process of osteolysis, comes from the small particles. So the small particle wear here is a problem. That's why the whole concept of mobile bearing did not work. Theoretically, they have less wear in volume, but they have more small particle wear, which is balancing the benefit of less wear. But again, if you look at the 10 years data, clinically no difference. It's a philosophy. Are you a mobile surgeon, a fixed surgeon? It's probably that what you train and probably what you believe. Now, very short to the modern designs, and if you have time, go to the booths, to the different companies, and you will find them all. You get a medial pivoting concept, which is a genius idea. So it's a ball and socket on the medial side and the natural motion on the lateral side. So all these modern designs have a target. They want to get the complex biomechanics of the natural knee back to the patient. And the knee has the most difficult biomechanics of all joints in our body. It's very complex. And in my experience with an artificial joint, you cannot get nature back. It's impossible. It's impossible. If you take the ACL away, biomechanics is disturbed. That's why we do ACL reconstruction in young and active patients, because without an ACL, the knee doesn't work. So in my experience, all these modern designs cannot give you nature back, because a total artificial joint will never give you nature back, except if you have both cruciates intact and you have an individual prosthesis. So this is the medial pivoting. Then you have the single radius concept, which means it's better in mid-flexion. You have this B-cruciate substitution prosthesis. This was a big hype a few years ago. They made this Camelback mechanism to substitute the posterior cruciate and the anterior cruciate. And just to tell you a short story on this specific implant. This implant was the best designed implant I've ever seen in my whole career. It was based on 10 top biomechanical studies, and the inventors of these implants were a friend of mine. And I told them, this is the best designed prosthesis I've ever seen. So the scientific background is perfect. But this prosthesis will fail from 3 simple reasons. One reason is 80% of the patients coming with a knee don't have normal biomechanics. You know, they come with a varus thrust, they walk like that, so they don't have a normal biomechanics for the last 20 years. So if you force them back to normal biomechanics, the patient will have no benefit. Even a risk, not a benefit. The second was, the more, and this is for all these modern designs, and this is important for the surgeons, the more sophisticated the design is, the more the motion is guided by conformity. So that means the more the implant drives the complex biomechanics, the less forgiving is the surgical technique. So for example, this B-cruciate substituting prosthesis is non-forgiving. if the surgeon makes a mistake by 2 millimeters in one of the bone cuts, this prosthesis doesn't work anymore. And I told them 80% of the surgeons, and I trained more than 3,000 surgeons, will not be able to put that in exactly as precise that it works. And the third argument was, I told them, you built the prosthesis like a Ferrari, but you gave the surgeon an instrument like a Trabi. Do you know Trabi? The former East Bloc car, you know? That cannot work. You give him a Ferrari, but instruments like a Trabi. And I told them it will fail, and exactly that happened. This prosthesis is taken away from the market. There was a big hype. They get all the scientific awards. It was promoted by a company worldwide. It's away from the market because exactly that happens. They get a warning after 2 years in the registrars that a lot of revisions happens, and a lot of surgeons exactly recognized, this is nothing for me. It's too difficult. A lot of my patients are not happy. And this is the story probably for all these modern designs. The more sophisticated they are, the less forgiving, and that's the problem for the surgeons. Do they get a better result? And the last development is patient-specific. That means you get, in an extreme, you make an MRI of the knee, and you make a special implant for this specific patient. A lot of money. The question is, has the patient a benefit out of it? Now, to end up this story, the new designs, all these new designs, and this is now, fortunately in the literature, this discussion has started, because it was very pushed by the companies that all these modern designs give better outcomes, patients will be happy, whatever. The literature changed. In the literature they say, okay, all these modern designs have to prove first that they are safe. That's the number one question. If you get a warning in the registrars, companies withdraw the implants, because otherwise they get legal issues. And the second is, they have to prove to be better. Why should I change something if it's not better? They're all more expensive. Don't think that you get a new car for a less price. No, no, you pay 30% more to drive a Ferrari. But the question is, has the patient a benefit? And what we are asking for is now independent RCT studies, randomized control studies, from non-developers and not financed by the industry. And these are coming now, and guess what? What is the outcome of these RCT studies? No difference. It is the surgeon with his skills and the patient with his risk factors. It's not the implant. Companies don't like that, but that's the reality. And more surgeons recognize that. So finally, very, very short, these revision systems are nice. You need that for difficult situations in primary and revisions, because you can have all these blocks and wedges to substitute for bony defects, and you have for better fixation this stems extension. It's like a fundament of a house. So if you have bad bone quality, you can use this stems extension in different variations to get a better fixation. And the RHK, again, the third generation, because the first generation hinges were designed in the 70s last year, it were a disaster. They had no rotation, so they had only a really hinge mechanism. Now you can imagine if the patient walks, there are always rotation forces, there are a lot of hyperextension forces, so they all failed, they were a disaster. And the second generation hinge, they allowed some rotation, but still no loading of the poly. And this third generation hinge, and all the companies have that now, the load on the poly, that's what you want. You want to have the natural load from the femur on the tibia, and the hinge is only to get you stability. So these third generation hinges have a larger box, but the poly looks like the PS, so they have the same kinematics like a PS, and it has that 90% stress transferred from the femur on the poly. But it gives you complete, if you see it, if you try it, it has complete stability in all 3 dimensions, and you can do fixation without long cemented stems, which was in the past necessary. And the nice thing is now, nearly all companies offer you a family of products. So you can start with a uni, which is a partial knee, to a total knee, to a revision knee, to a hinge, in one family using the same instruments and the same philosophy. So you don't have to switch during surgery. You start a difficult primary with the company A, which offers you only a primary knee, and then you have to go for more constraint because it's difficult to get everything out of the UR. And you get everything in the UR, it's a disaster. So most of the companies offer you now a family from A to Z, whatever you want. So for these specific, and they're much more expensive, these third generation hinges, we have specific indications at Stolzer where we use them. If the ligaments are not there or the dorsal capsule is insufficient. Interestingly, if the extensor mechanism doesn't work, you go for an RHK because in deep flexion, this CCK can dislocate. If you look at the CCK, it has a nice stability here, but if you go in deep flexion and the extensor mechanism is not here, it might dislocate. So this is the reason why we have an indication for an RHK if the extensor mechanism doesn't work, or if you change the joint line, which is rare, or if you have a patient with recovatum, we go for the third generation hinge because this has a recovatum stop. No other implant can do that, but the RHK can give you this recovatum stop in the stability in the sagittal plane. And if we do large constructions, bony construction of the proximal tibia or distal femur, we also use that RHK. So the last point of my talk is why do modern designs still fail? And they fail. First of all, OR knees have no normal biomechanics when they come for surgery. So we have to make a simple correction of the mistakes why nature failed. And I told you already, all these modern designs which want to bring nature back, in my experience, there is no benefit. The only benefit might be in a young patient who has a normal biomechanics when he comes for surgery, that you don't destroy that. But this is maximum 20% of your patients. 80% already have not a normal biomechanics. And a total knee, in the form as we have it now, does not give you nature back. If you want to get nature back, the best solution is a uni. A uni is you keep your ACL and your PCL and you just resurface one compartment which is destroyed, the medial or lateral. And in a young patient with an ACL, PCL intact, a uni is a good option and it gives you nature back. You just resurface the cartilage, you don't change the biomechanics. But with a total knee, again, it's not possible. That's at least my experience, and you will see in 10 years all the companies will still try to bring components on the market to give nature back. Again, I told you already, the more sophisticated the design, the more guided motion by the implant itself, the less forgiving is the surgical technique. And the final point, that this is something I work now for 20 years, is the surgical skills. If you have the most sophisticated implant, and you don't have the surgeon to put that in precisely, and precisely means 1 or 2 millimeters accuracy, it doesn't make sense. So we probably need complete different instruments, and if you go to the booth, you will find now robotic surgery as the last solution. So they designed haptic robots, where you do a 3-dimensional model of the knee, and the robot arm guides you, and it's very precise, less than 1 millimeter precise. But you need a $1 million robot to do the case. It takes a long time, but probably that's the future, to be more accurate, to use robotic surgery in arthroplasty surgery. I don't know. I definitely will not do that in my career anymore. So what is the indication for revision surgery? Again, if you look at the registrar, we cannot get rid of the infection. So infection is one of the problems. 1 to 2% of all the knees we do or hips get infected. And that's a disaster for the patient and a disaster for the surgeons. So 20% of the revisions we have to do is the communication of the infected cases we have. But then we have a lot of aseptic failures, early loosening. A modern implant should survive 15 to 20 years, so if they lose earlier, it's a problem. Patella problem, that's the problem that the patellofemoral joint is the most painful and most difficult part of the knee. If the patella is not working perfectly, the patient is not happy with his knee. Instability means he has not a stable knee, Either the surgeon chose not the right stability with his surgery, or he could not deal with the ligament situation during surgery. And finally is polywear. And again, the modern implants should not have any polywear problems for 15 years. So if it's polywear earlier, there's a surgical mistake. So something went wrong during surgery. And one of the problems is that in the registrars, the reporting of the failure was related only to these topics. Now we have more modern literature where they go in more detail, and this is the first classical paper published in 2002 looking about the series in the last century. So this is 15 years ago. And again, what they showed is that more than 50% of the revisions we have to do is in the first 2 years. And if you exclude now the infection cases, all of them are a bad primary surgery. So the first surgeon did not do a good job, so the patient has to come for early revision surgery. So again, 18% were infections, but the aseptic failures is instability, a surgical mistake. Either he used the wrong component or he did not deal with the ligaments. Early loosening, bad cementing or bad alignment. Malalignment, that means he did not correct the varus or valgus deformity, or polywear. And you see arthrofibrosis is here in red because at this time, 15 years ago, they thought arthrofibrosis is a real disease. Arthrofibrosis is not a disease because arthrofibrosis is if the soft tissues get scarring tissue. That's a genetic defect, and the Mayo Clinic identified even the genome where that happens. That's very rare. But if you have a chronic inflammation or a permanent overloading of soft tissues, you also get scarring. That's a natural process, and that's called secondary arthrofibrosis. And this is again if the surgeon made a mistake. So primary arthrofibrosis is very rare. And this is now the latest paper in 2016. They looked at recent failure modes in the last 10 years. And again, 60% done in the first 3 years. That's really the bad news, that the primary implantation at the knee side is not as good as the hip side. Again, infection, this is the old paper, this is the new paper, it's the same. About 15 to 20% we have to deal with the infection problems. But if you look at the aseptic failure, instability has stayed the same. So we surgeons did not learn something in the last 20 years. We still have 20% patients which tell you they tell you all the same. Doc, I had arthritic pain. And arthritic pain is a typical pain. You have starting pain when you start walking, you have night pain. And they tell you, my arthritic pain is gone, I have now a different type of pain. I can walk even ground, but if I want to go up and downstairs or raising a chair, I have pain, instability, and sometimes I fall down. And this is again a surgical mistake. Hadn't changed. Loosening, a little bit better, because the cementing technique and everything was a little bit improved. Malalignment, significantly better. Because the teaching in the last 15 years, we were really focusing that you put the knee in all 3 dimensions in the right alignment. So there was a significant increase. Arthrofibrosis, significant decrease because they recognized that the 70% were the wrong diagnosis. So it's down to 4%, and you see polywear, significant decrease. So the message is again, we learn something, we get better, but not in every single step. And that's why training and education for knee surgeons is so important. So we did an own study. Again, we are a referral center, so our infection rate is a little bit higher, 28%, because we get the infected cases referred. But again, we found what is now in the latest literature mentioned, that the 3 main problems after total knee is malalignment. That means the surgeon did not correct the frontal, the sagittal, or axial plane deformity. And if nature failed, cartilage failed because of this deformity, and you put in plastic and metal, and you don't correct the cause, do you think the metal and plastic will survive? Never ever. So if you don't correct the alignment, you will fail. If you don't correct the axial malrotation, and if you make a mistake to balance your knee, instability 20%, you get a problem. And these are the 3 main problems, and they make secondary the patellar maltracking, the early loosening polywear, the stiff or unstable knee. So in summary, 80% of the problems at the knee side is the surgeon, not the patient, not the implant. It is the surgeon who did not do a good job in his first case. One of the difficult stories is the looks good, feels bad patient. So this is a patient, a very young patient, after post-traumatic osteoarthritis. If you look at that X-ray, and even if you're an expert, you will say that looks good, the alignment is good, the fixation is good, here is a stem, well done. But the patient will tell you, I hate my knee. Looks good, feels bad. And these are really a challenge for the surgeon to find out why is this look good knee so bad. The patients go from one center to the other. Everybody tells him, look at the X-ray, it is fine, you're probably crazy or you don't want to work. For the patients, it's a disaster. Some of them get already secondary depression, they get psychological problems, because if you tell you every day the pain you feel is just here, you are crazy, you will not be normal, even if you were normal before. And some of them had all legal consequences, because this patient lost his job for 2 years and he sued his first surgeon. Because he said, I got that surgery and after that surgery I was not able to work. So this is a problem. And what the surgeons have to learn now to get through a diagnostic algorithm, and the most significant message is, trust your patient. So if a patient comes and is complaining of pain, trust the patient, he has pain. In my experience, 5% of patients are crazy. They have secondary gain of the disease, they don't want to work, whatever. But 95% of patients have really a problem. So take it seriously. Don't send him away and say, come on, I'm a big surgeon, look at the radiograph, you are crazy. Take it seriously. But identify the 5% crazy patients. And we at Stolzalpe, we have a chronic pain team with specialized psychologists, and they find out in these patients what is the problem behind. And for a surgeon, it's very important to identify the 5% crazy patients. Because if you took the knife on a crazy patient, you marry him for the rest of your life. He will sit in your office every week. And either you marry her, or she will come every week. So be sure that you identify the 5% crazy patients, but in 95%, trust the patient. And my experience is, if I see something like that, or we are the referral center, we can solve the problem. But if I'm a knee surgeon and I see that, trust the patient, tell him, look, I tried everything, I tried to make it perfect, I trust your pain, but I cannot explain it. But I will refer you to a referral center and they probably will help you. And the patient goes back with a bottle of wine to the first surgeon and says, thank you, you brought me to the right place. If the surgeon tells this patient, look, you are crazy, look at the X-rays, you just don't want to work, you go to the psychiatrist, he will sue him because he lost 2 years of his life. So what we did, we published an algorithm in 10 steps how to find out these looking good bad patients. And even this is a worksheet done by my teacher, Kelly Wins, where the surgeon can follow these steps. And we always tell the surgeon, take the complaints of the patient seriously, go through all these 9 steps. And if at the end of the steps I cannot find any orthopedic information what's wrong here, I will never tell the patient you are crazy. I will tell the patient, look, I'm an orthopedic surgeon, I tried now everything, I trust your pain, but I cannot find an orthopedic explanation. Let's look at other points which might be behind, and then we send them to our chronic pain team and they find out secondary gain of disease and whatever. So in conclusion, and this was the topic of my talk, the implant choice. You can, if you are a surgeon and you want to choose which is the best implant for my patient, you can look at the survival rates, we discussed the limitations, or you can look at the functional outcomes of the literature, but I already showed you there are some limitations and biases. And finally, you have a personal preference. You like to drive a Ferrari, a Mercedes, whatever. So it's a mixture of everything. What is the right implant choice? You have three options, three classical options, the CRPS and rotating platform, and all the modern designs you will find here at the booth are a further development of one of these classical designs. Are modern designs better? You see the questionnaire, all the data we have now, and believe me, the industry is pushing a lot to get real data to convince surgeons that their product is the better one, but you see the questionnaire. So far, I know only a few non-designer papers where there is a minimum difference between different designs, and this is the question, is that really, has that a difference for the patient? So in my experience at the moment, no, it's not the implant, it's the surgeon and his surgical skills. If you have difficult patients or revisions, you need that CCK or RHK designs, but in 80%, and this is what we tell in every course with the surgeons, and this is for me the take-home message of my teaching, 80% of the revisions we do nowadays in total prevented if the first surgeon does a good job. So training and education, knee arthroplasty is the key, and we have to be aware that we surgeons are the main risk factor for our patients.